Hi, good morning. I am Dr. Ravi from the University of Madras. Uh, at the outset, I want to thank Professor Daryl for inviting me here for this conference, along with my mentor, Professor Aruna Sivagami. And the topic today, which I am going to present, is public health organization in India and US, a comparative, just an analysis. As you all know, just I want to be very brief. Now I am going to just pinpoint some of the salient features of US healthcare system. That is, what is the role of government through Affordable Care Act, ACA 2010, for good quality health insurance, and the health centers concentrating on Medicare and medical aid services, CMS, and SHIP, Children's Health Insurance Program, for the state population, federal state programs for certain low-income groups, and of course the private insurance that is being regulated at the state level mostly. And second important point here is to be who is covered and how is the insurance is financed. That of course most of us we know how the public programs are covered, and for the migrants since 2015 around 67% of US residents received health coverage through private voluntary health insurances, and so on. And what is covered generally under the insurance schemes by the public and private healthcare entities in US? The services generally covers some 10 essential health benefit categories, starting from ambulatory patient services, emergency services, hospitalization, maternity, newborn, mental health services, etc. And of course, the private insurance plans sometimes use narrow networks to the healthcare providers.
Change the page.
And Medicare provides coverage for hospitalization, physician services, and voluntary supplementary program, prescription drugs, etc. And of course, the very important aspect here is the cost sharing and out-of-pocket spending by the insurance holders. Here, the cost sharing provisions in the private health insurance plans vary widely with co-payments for physician visits, hospital services, prescription drugs, etc. With a minimum annual deductible of USD 1,250 per individual or USD 2,500 per family. The Medicare is really a cost sharing, and sometimes it has a pinch on the patients. And some safety nets like medical aid, CHIP and ACA is being implemented in most of the districts and states in US. And the health delivery system in US is generally by the public sector as well as by the private corporates. Publicly financed health care, according to 2014, spending accounted for about 49% of the total health care spending in US. The expansion of medical aid of the ACA is currently fully funded by the federal government throughout 2017. After which the government's funding share will be phased down to 90% by 2020. And the privately funded health care insurance spending accounted for 39% of the total health care spending in US. And when we come to the primary health care, the physicians account for roughly 1/3 of all US doctors. The majority operate in small self or group-owned practices with fewer than 5 full-time or equivalent physicians, and so on. And then the outpatient specialist care is really very important here, as we see in most of the states in US. Specialists can work in both private practice and hospitals. Some insurance plans, such as health maintenance organizations, require a referral by primary care doctor to see a specialist and limit patients' choice of specialist. And then the administrative mechanisms for paying primary care doctors and specialists. And the next one is after hours care, which requires pertinent importance because access to primary care is limited to 39% of primary care doctors in 2015. Then the hospitals can be non-profit, 70% of the beds nationally, and for profit 15 beds, hospitals can be non-profit, approximately 70% of the beds nationally, and for profit 15% of the beds, or for public 15% of the beds. They also take care of the mental health care, which is becoming very important in most urbanized capitalist centers and states. Then long-term care and social supports. And the fifth one is the health system governance, which plays a very major role in US, and it is a very healthy model when we compare to most of the capitalist countries, and of course as third world countries, some of us envy those programs of policy making and implementation in this regard. The US Department of Health and Human Services is the federal government's principal agency involved in healthcare services within the HHS, which include Centers of Medicare and Medicaid Services, Center for Disease Control, National Institute of Health, and so on. It is more than 10 points, most of us know. And the National Academy of Medicine, formerly the Institute of Medicine, an independent non-profit that works out for the government, acts and the advisor to policymakers in implementing healthy healthcare modules that benefit the society at large. Then the major strategies to ensure quality health care since 2012 were mainly dependent on the Department of Health and Human Services, released by National Quality Strategy and so on. And the CMS has moved toward increased public reporting of provider performance, which becomes relevant for evolving strategies in healthcare. States have developed additional public reporting systems and measures, including that ambulatory care, consumer-led groups such as Consumers Union and Leapfrog Group, etc., which closely lead to consumerization. Incentives to reduce avoidable hospital readmissions among Medicare patients. And HHS also set goals for 80% of traditional medicine payments to quality or value-added treatment. And the next important area is to reduce the disparity among the various ethnic groups. And the eighth one is the delivery system integrated care coordination, which involves Medicare and medical aid for all the patients throughout United States of America. And then finally, which is very interesting to most of the Indian healthcare providers, is the electronic health records, which of course in Indian hospitals they are not up to the mark. And it is very interesting, I can even tell you, in most of the hospitals, particularly at the primary level and at the tertiary level, the case sheets are not written in time immediately after the surgery. Only the owner of the hospital has to write the surgery reports sometimes, because most of the doctor colleagues know this better than. But of course, in the case of US, most of the medical practitioners spend a lot of time on preparing the documents. Then only you can meet the doctor, or you can have the session, or his Medicare expertise, everything. But the paperwork is really marvelous and time consuming. That is why most of the patients cannot meet the doctors immediately as we do it in India. And it's with this few major things, of course, there are various reforms has taken place in US, starting from Affordable Care Act to various acts like CHIP, reauthorization, etc. The reforms under MACRA are meant to support the transition of US healthcare system from free of service payment to payments based on value and quality of care delivered. They are intended to generally promote approaches to care delivery focused and better care, efficient spending, and healthier patients. And when we talk about with this model taking into mind, if we just try to aspire and get some of the policy models from US to India, we find it really very difficult, because on one hand we believe in mixed economy. So the government is interested in promoting healthcare, private healthcare very much, because it is unable to match the public sector health provisions to meet the population which is exploding and the rural-urban division and so on. Here the private players come into the scene to promote private healthcare organizations development and changes, because the government law by the government legislators as well as the regulatory agencies like Indian Medical Council and Medical Council of India and the ICMR in India, and all those things are meant for regulating the hospital healthcare system development and particularly the private healthcare. To some extent they were not very happy to control them, or they are not effective enough to control these people. That is why there is a tremendous growth on profit making in spite of non-profit making agencies, which involves healthy NGOs very much interested in healthcare provisions to the masses in a big way. Here, when in comparison to US healthcare system, there are some 6 important areas which makes further difficult for the government as a service sector to be a number one player in meeting healthcare challenges, issues and challenges. That is the reason why the private players, in the name of a corporate culture and corporate hospitals, they do a marvelous job by cutting down the cost when compared to US India for each and every diagnosis or organ donation or fertility or infertility or spine surgeries or cosmetic surgeries, and particularly in fertility. It has become a booming industry in South India, particularly in Chennai. There are mushrooming growth of multiple corporates coming up to deal with fertility agencies with alternative medicines, substituting the allopathic medicine in general, and the healthcare providers and the third-party administrators play a very role with the help of insurance agencies to make the effective payment mechanism in this health sector particularly. And of course there is a big demand for basic primary health care in our country, which is very difficult to manage by these people. In the name of brain drain, the government who spends a lot of money for the doctors, they just leave the country for better placements globally. And this brain drain has a tremendous impact which is obstructing the primary health care system, and also the people who are studying and coming out after MBBS, they are not paid properly. Their payment is, on comparison with other professions, it is very less, and in this context they go for corporate employments where they get a big salary package, a fat salary package, and they enjoy. In spite of these allopathy additions, which involves a major role in playing the governments and also our collaboration with Professor Arna Sevami Madam, other things, we thought of suggesting a 3-year rural MBBS program or a 1-year contract for the rural MBBS doctors. Doctors to work in the rural areas have become pertinent to manage the primary health care. And of course, side by the pharmaceutical industry has enormous scope in this sector, wherein most of the pharmaceutical companies have just started their own corporate hospitals in different parts of the country, and Madras, Chennai city is no exception in that case. We have Fortis, Malar hospitals, and we have global hospitals, and we have Chennai medical centers and Apollo hospital, which is very familiar in India and South India in particular. And Chennai is a very important place for the growth, tremendous growth of Apollo group, which involves not only in health insurance, pharmaceutical sector, and so on, even including the medical devices import and export. They do a lot supporting this organization. The alternative medicines in this context are many, because we have our native medicines like Ayurveda, Siddha, Naturopathy, Yoga, and Panchakarma, and all these things, which is very much affordable to the poor, as well as now the people at large now going for alternative medicine and naturopathy for important diseases such as even cancer and fertility and other aspects, and for TB and everything. And even some people, even they don't believe in vaccinations. They take naturopathy medicines to cure certain communicable diseases which is prevalent in most parts of our country. Of course, the central and state governments are also interested, right from being clean and cleanliness and having sanitation, rural health mission and our health mission. There are so many programs and policies which are being implemented since independence or since the 5-year plans, and it is continuing, and the money spent by the government is not sufficient. That is the reason why the private health organizations are developing with leap and bounds, and they are doing a very marvelous service. Only the cost factor is not effective. The cost effectiveness, they are trying to cut down the cost for various things, particularly in organ transplant, which costs a heavy budget in US or UK, is very much cheap in India, in Tamil Nadu in particular, which is a medical hub or medical tourism hub in the whole of country. We have tremendous scope for health tourism in this context, I will tell you, which is another profession growing side by along with this private healthcare professionals who are really professionals, and there is social and economic development and so on. In spite of all these things, the CSR is becoming very important in this context, both by indigenous medicine and allopathic medicine. Most of the big corporates now are concentrating on CSR and becoming responsive healthcare professionals and administrators to give the effective medical healthcare and to solve some of the biomedical waste material, and being professional, following the professional ethic principles that we are talking about, bioethics or professional ethics in this regard. And agencies controlling these things are the environmental departments, the pollution control board departments, the NABH national accreditation departments, and of course the government of India has developed model hospitals like AIMS, which we see in US corporates like Geisinger. In most of the states, most of the American friends must be knowing about Geisinger and the Madison Health Center and so on. And the insurance companies are plenty in number. They are of various types, looking care of the individuals and the needy persons, and the corporate employees and the employers funding for the benefit of their employees to motivate them and to make them stay back with their as healthy professionals, following some of the principles like management by objectives and developing marketing strategies so that they can increase their income levels and also take care of healthy personnel and so on. And in the case of fertility, of course, we have some traditional belief also. In Tamil they used to say famous lines like the human being must be a healthy human being, should not be any without any abnormalities. He should be healthy. In Tamil, a famous poet Avayar used to say this. And of course, there are also some traditional beliefs, religious beliefs. To have children, people used to go around Arsamaram. So such beliefs are still there. And what is required at this juncture is marketing in a big way, because specializations have started marketing of healthcare products, healthcare delivery system, and the efficiency and medical tourism in all walks of healthcare. And side by, the government is unable to control the corporate healthcare centers with strategic laws and regulatory agencies and special laws, particularly in the field of fertility, organ transplantation, eye, cataract eye, and so on. And here, most of our researchers in the line, they are also thinking about public-private participation to enhance the health care system in our country and so on. because on the other hand, the Indian patients as a consumers, they are very active, and consumer activism is taking place in all walks of life, particularly in the healthcare, and which is supported by judicial activism at times when they crop up with medical negligence, and at this juncture the doctors are now being sued at any point of time if they commit some error or like that of in the USA and other things. So the doctors now, they go for medical insurance themselves against this medical negligence in indemnity insurance and so on. With these few things, of course, here management is also required. Strategic management policies and practices have to be followed to enhance the potentialities of professional doctors and the consultants, the diagnostic technicians, the ultrasound experts, and the MRI experts, and so on. And these healthcare modules are being developed, of course, by some of the research centers like Indian Institute of Public Administration, Indian Institute of Management, University College Hospital Administrations, and some state and central level consulting agencies, and so on. And to substitute some of the policy additions which can enhance the practitioner medical practice, particularly the concentration of medical professionals in allopathy, homeopathy, or whatever it is. In government, once they are given elective subjects, as my mentor pointed out, about bioethics or about native medicine or whatsoever, that's so fantastic. But the government doctors, they work, they are not completing their 8 hours work or 12 hours work at a stretch. They go to the office, sign and do some assignment, and they just keep away concentrating on private practice. It's high time that most of the states have cut down private practice for government doctors, but it's high time Tamil Nadu should do it. And we noticed in our study, and instead we can give non-practicing allowances for the doctors, as some of the corporates, public enterprises used to give for the doctors. They give a small package of non-practicing allowance to enhance the doctors' attention towards the masses, towards the poor, towards the needy, towards the sick. And of course, in this regard, as my Professor Aruna Sivami mentioned, the NGOs play a vital role, the non-profit making organizations. In Chennai, we have plenty. Right from Tamil Nadu, we have CMC Vellore. We have Triple M Hospital in Pondicherry. We have in Chennai itself, we have Triple M Hospital. We have CSI hospitals. We have Hindu missionary hospitals. And we have Narayani Hospital in Vellore, in Karnataka. They are concentrating on super specialty subjects, right from heart surgery to stent or whatever it is, or kidney transplantation or eye transplantation or cataract transplantation with Paco lenses and so on. And in this regard, the NGOs and the private corporates are doing a very good service to a great extent, but they are into business. On one hand, even the governments have tried to take healthcare into a business sort of, at least to manage the funds. That's why they have got clubbed with some of the national insurance companies providing healthcare facilities in the name of Chief Minister's Healthcare, which provides the downtrodden and the poor and the needy. And in this context, I should also mention the tremendous growth of our ambulance service systems, like you have in US and other capitalist countries. 108 means it's something very close to 911 in US. Anything and everything concerning healthcare, these people come for the rescue for the poor and the downtrodden, and whoever it is, the healthcare institutions are moving towards private sector for better salary, for better working conditions and better environment and better motivation. With this, I stop. Thank you very much.
Okay, thank you very much. Thank you, Ravi.
Thank you.
So, who would like to ask some questions?
Yes, please.
So, can I ask firstly yourself, do you prefer to go to private or public healthcare when you get sick?
Definitely I'll go to private because we don't believe in public sector, most of us. You can ask my mentor also.
It is difficult for us to
Yeah,
get
difficult.
proper treatment
Yeah.
as well as.
Daryl, in this context, can I add one
Yeah.
more addition?
Yep, go ahead.
Yeah, because in most of the private hospitals, when the case is something like operation success, patient died. If you have a patient to get beat the fatally death, we will send him to GH, general hospitals. Most of the cases, but at the same time they do better work. They have to be appreciated for better work also.
I see. Right. Other comments? Is that the same in most countries though? Private healthcare is usually better than public.
Well, if you compare it to, I don't know about most, but if you compare it to an Asian country and being an immediate neighbor, Pakistan, it's the same thing that private healthcare is much better than the public healthcare. In public healthcare, you have to have long lines and people are waiting, getting impatient, and at many times we encounter death. The patient doesn't even manage to reach inside and he's already expired. Then again, because of that ethics issue, people start raising ethics, that is it ethically correct to make a patient wait this long if he's under emergency. But then there's another issue which comes against that it's first come, first serve. So ethically, if he's late in line, then he has to wait for his turn. So a lot of debate is going on that, and obviously many people, because of that, they prefer the private sector compared to the what you call public sector.
Okay.
Yeah, even in India,
Yeah.
actually, there are so many doctors who are owning private healthcare organizations, and many foreigners come to India for organ transplantation, or if it is going to be in vitro fertilization.
Yeah.
For mostly, the foreigners come because in England they have to pay 17 lakhs
Yeah.
if it is going to be an organ transplantation. But if it is going to be done in India, it will be just 1.5 lakhs.
Yeah.
And totally they would spend only 3 to 4 lakhs for staying, for getting operation, then for getting cure, and then go back to London. But if they are going to be in London, they'll have to wait. They'll have to stand in the queue,
Yeah,
waiting for kidney, waiting for heart, waiting for liver, any transplantation. They'll have to wait for a very long time. There will be a very big queue. But in India, there will not be a very big queue. You will get organs very quickly. And even
Thanks
if
to
it is
Professor Aruna with your permission.
Yeah.
Particularly in the context of fertility and infertility aspects.
Treatment also.
Treatment. Now they have cut down from lakhs to even thousands.
thousands.
They can do IVF or even surrogacy. To that extent, they are highly competitive. I can tell you it's a cutthroat competition.
Only
As
if
my
it is-
friend Assam said, there is a saying we usually among the doctors they used to say, and even it has come out in the cinema and other things also. Only doctors can wait, but patients need not wait.
And even if it is going to be fertility treatment,
Yeah.
see, they'll have to spend only 1.5 lakhs to 2 lakhs.
2 lakhs, that's all.
Yeah, Ayurveda and Siddha, they give
They are
Ixi for men and tablets for women.
Yeah.
It costs only 1.5 to 2 lakhs. But if it is going to be allopathy,
Yeah.
they'll have to spend little more.
A little more, that's
More.
all.
But you said they are foreigners, and foreigners can easily come and
Yeah.
over there.
Even the locals.
The real problem is that even the locals, they prefer the private sector, but there's a big mass of difference between the poor and the rich, especially in the third world countries, Pakistan included.
Yeah.
And those are the ones who have no option and they just have to go to the public sector because for them it's just life and death over there. They can't afford the private sector, and then again the point
No,
of
but
ethics
even
comes.
Pakistanis, they come and prefer only private health
Yeah,
care
private health.
sector. They don't go to the public
I'm
sector.
saying that, but
Yeah.
I'm talking about the social D or the social E class, the absolute bottom class who cannot afford the private sector. They're stuck, but obviously the first preference of anyone, including myself, would definitely go towards the private sector compared
Yeah,
to
but
public.
in private sector, you go for what you call indigenous
Yeah.
medicine. You don't go for allopathy. Because even if it is going to be private healthcare sector, and if you go to private healthcare, allopathy means, then you'll have to spend a lot.
Exactly.
So that's the reason why I'm saying that is why private healthcare centers, Unani, or if it is going to be homeopathy, or if it is going to be the fertility treatment, then they'll have to go for Ayurveda and Siddha, because that will cost only 1.5 lakhs.
Vivek?
1 minute before he starts. In this context, particularly in the case of fertility treatment, the government has intervened in almost every state of our country, particularly with the ultrasound doctors, because selection of sex is not a problem in US. But in India, a scanned doctor through ultrasound, she or he cannot say your baby is going to be a boy or a girl. That's a very offensive in our country.
Right.
Yes, please.
No, I just want to add that in South Asian countries, the public health system is less practical than the private health system, I guess. Because we are more used to private health system.
Yeah.
We are not that much fond of
Public health.
system. That's why we
But
prefer
of course, in this
private
context,
health
as he
system.
rightly picked up, our state governments have introduced the Chief Minister's Health Insurance Scheme, which is very much helpful. As Assam said, even a downtrodden people can take up any surgery or including fertility to a great extent. But of course, fertility has not picked up, as Madam said, in government hospitals. Still, there is only 10 by 10 room with a slide saying this is a fertility center. But nobody goes there. They don't have belief or faith in public sector fertility centers.
Right.
On the other hand, the private are doing a marvelous job.
That's what-
Highly scientific, highly high-tech professionals.
That's what I'm
They study in US or UK, come to their native towns and do good business and good service, of course.
And I have to one thing that behind this all these events
Yeah,
in mostly in
Shall I
South
go?
Asian countries,
yeah,
doctors have gone beyond the medical ethics.
yeah. Beyond exactly. That's why
That's the
consumer
number
activism
one.
is taking place.
Yeah. Because the doctor who gives the same service in the public institutions is quite different than a person in
Yeah,
private
exactly.
institutions.
Really, it's a pitiable thing.
Yes.
The victims
That's
are
what
nearly
we
the
have to
downtrodden.
In India, as you told, most of the people go there for the
Private
organ
transplant.
transplantation. That is behind that cases. There is also bad practices in medical ethics.
Definitely.
I think because that has brought lots of bad things. Like many people, even many people from Nepal, are being victimized of wrong way to sell their organs in
Yeah.
India.
And,
That directly connected to
yeah, exactly.
Nepalese economy too, Nepalese population too.
Yeah, and finally, we all should thank profusely our Professor Daryl for coming up with the innovative ideas in the context of medical ethics, bioethics, and professional ethics, particularly in the healthcare sector.
Actually, he was responsible
Yeah.
for signing the MOU, but he never comes and stands for the photograph.
Yeah,
It will be published in the paper. It will be Brigitte Jansen or Irina Pollard. He won't come and stand. He'll be, say, a person who will be taking photographs.
directors always be behind the scene.
And,
Great director.
But he is the one who
Yeah.
has been very important in
Thank
trying
you,
to
thank you. Really,
bring about the syllabus for an elective.
yeah.
That's why we respect him, we appreciate him.
Yeah.
All the vice chancellors, they used to
Yeah.
consider him as the best person.
You are very familiar, Mr.
None of the
India.
acts which are passed
Yeah.
either in US or in India,
Yeah.
it is not being followed at all.
Followed at all.
People follow what you call
Policy is different and practice is totally different.
Yeah.
It never coordinates.
This is a global dilemma. Does anyone else have any questions on Skype? Any questions?
Yes, I have a question. How the public-private partnership can help to hasten the ICTs, the information and communication technologies, for example, with QR codes or apps, to reduce the financial burden of the administration of public health care in order to avoid a catastrophic out-of-pocket expenditure. Thank you.
Thank you, Manuel.
Then for
Okay.
I didn't get it.
Yeah.
So in-
Public expenditure.
Yeah,
from the
in
pocket.
Spain also it's a big issue, yeah?
Public expenditure is.
So, but in Spain, Manuel, do people, how many use private as opposed to public? Most use public, don't they?
Yes, the public health insurance is not worse than the private one, but the private one is far more fast to schedule a date with the doctor and to make some analysis and this kind of things. You pay in order to skip the road, but there is not a high quality plans because the public health insurance, when it seems that it's needed, can send you to a private center to make, for example, a TAC, and the private center sometimes has agreements with public centers. There is not a binary, there is not a dichotomic border between public and private, because the money that is used is theoretically accountable. So it is not a great problem. If you want to pay to save time, well, you can do, but there is not a gap in comorbidity besides the natural gap from being attended later or sooner. Thank you.
They
Thank
have
you,
an agreement.
Manuel.
Private and public
Public
healthcare centers, they
Yeah.
agree with
Yeah,
one another.
good
That's
agreement.
always there.
Yeah.
Yeah, well, I think it's very important to have a coordinated system
Yeah.
to integrate it somehow.
Oh.
In India, do the same doctors work in public and private sector? In New Zealand, for example, they may work 1 or 2 days a week in
Yes.
public and 1 or 2 days in private.
I'll tell you what's happening
Yeah.
in India. Particularly the top specialists, the super specialist doctors in government service, they enjoy so many privileges for getting higher education from MBBS to MS, MS to MCH or MD to DM and so on in the name of government quota. Government reservations are there. So they do all higher education, get all higher education facilities and go for super specialization and they spend most of their time only in private hospitals.
Yeah.
Not in, they go sign there and see a few patients and they escape. All the PG students will take care of the patients. The real casualties for the PG students are the public. Public become the real casualty.
And
to
the
PG
government
students.
doctors, they have their own, private
setup.
clinics and they have their own patients.
As well as they go to the
making a lot of
corporates.
money.
They go to the corporates now that it has become very easy with their mobile phones. 24/7 they escape at any time. And this control over the government doctors is becoming very poor by the government agencies because once in a way they go for a surprise visits. They catch hold of some primary center doctors who are just a graduate. They don't catch hold of super specialty doctors. And nowadays they are even advertising in, they are coming up in TVs and advertisements saying that I can do wonders, you please come to my private clinic.
And in primary healthcare centers also, most of the doctors, they don't go and stay from morning 10 o'clock to evening
Yeah, they're
5
supposed
o'clock.
to stay.
They don't. That's the reason why we are compelling people to go and practice in the primary healthcare centers.
They should be, otherwise even the registration should be cancelled.
Cancelled.
Only people, when you have become closely supervise them, only they will become good.
Okay,
Thank you.
thank you very much, Ravi.
Thank you very much.
Thank
Professor.
you.
Thank you.